Welcome to the MedControl Monthly Podcast, brought to you by the Oakland County Medical Control Authority. This episode was recorded on September 19, 2022. The Oakland County EMS system is made up of 49 EMS agencies and 15 hospitals that serve about 1.3 million residents with approximately 250,000 calls for service each year. It requires a constant stream of high-quality information to support such a robust and busy system. The mission of MedControl Monthly is to provide the latest updates, information, and trends to and on behalf of Oakland County MCA's EMS agencies and hospitals. I'm Geoff Lassers, and I'll be your host. I'm the EMS System Manager of the Oakland County Medical Control Authority, as well as a full-time firefighter paramedic with the West Bloomfield Township Fire Department. In today's episode, we are joined by Bonnie Kincaid, the OCMCA Executive Director, Dr. Steven.McGraw, our EMS Medical Director, and John Theut, our MedControl Quality Improvement Coordinator. During this episode, our guests will describe why and how all COVID-19 emergency protocols were suspended effective September 23, 2022. Then our guests will help us understand the difference between state protocols and OCMCA protocols. Specifically, they'll describe which EMS protocols to follow when working within Oakland County, Michigan. In addition, Bonnie, John, and Dr. McGraw will describe how and why the state EMS office, as well as the OCMCA, communicates directly with individual EMS providers via email. We finish off the conversation by providing an update of the OCMCA protocol's 3-year review process. If you don't know what that is, we'll fill you in. As always, check out the episode description for additional info and links related to today's topics, as well as a list of today's guests. Thank you for listening to the MedControl Monthly Podcast, providing the latest updates, information, and trends to and on behalf of Oakland County, Michigan's EMS agencies and hospitals. Now enjoy the show. Bonnie, who are you, what do you do, and where do you do it?
Hey, Geoff. I'm Bonnie Kincaid. I'm the Executive Director of the Oakland County Medical Control Authority for the past 26 years.
Well, welcome. John Theut, who are you, what do you do, and where do you do it?
Hi, John Theut. Hi, Geoff. How you doing? QI coordinator for the Oakland County Medical Control Authority. Been here rolling on almost 2 years. Been in the system for a little over now 27 years. I was the EMS coordinator for Ferndale Fire.
Well, thanks for joining us again today, sir. And last but certainly not least, Dr. Steven.McGraw, our EMS Medical Director. Let everybody know who you are, what you do, and where you do it.
Morning, everybody. Good morning, Geoff. As you indicated, I'm the EMS Medical Director for Oakland County Medical Control Authority. I'm also a full-time emergency physician who practices emergency medicine at Ascension Providence, Southfield, and Novi. But what I do, I would argue, is more easily summed up like this. As EMS Director, my job really is to work for the providers and the MCA so that we can all work and make certain we provide the best care to our patients as humanly possible across the entire county. And within our region, fulfill our obligations to our state EMS statute. We do that as a team, but we never forget who's the most important member of that team. And that's the folks that are at the patient's bedside. And you're who we do this for, because if you do it for the patient, we have to do this for you.
I'm not going to lie. Steve McGraw is an awesome dude to work with.
Well, thank you, Geoff.
One of the things Dr. McGraw does is help facilitate emergency protocols when needed. And everybody knows in the last couple of years, we had the COVID emergency protocols. In recent months, there's been a need to evaluate the need for suspending these protocols. And as of September 23rd, all COVID-19 emergency protocols will be suspended. This was announced recently by way of an EMS advisory. So before we get into which protocols are ending and which ones I should follow, first of all, we let everybody know via an EMS advisory. Bonnie, what is an EMS advisory and where can I find them?
EMS advisories were developed about 10, 15 years ago. We started sending them out when we really needed to communicate something important to our providers, our EMS coordinators, and we've been doing ever since. All of them can be found on our website, ocmca.org, as well as on the OCMCA protocol app under bulletins. So if you click on the app, you click on bulletins, you'll find all the OCMCA EMS advisories.
You know, one of the great things about that app is that you can allow for notifications, and then the OCMCA can push out push notifications to everybody who has the app. So I have it downloaded so I can access all those protocols on actual calls, but I also have it set to receive those notifications so that when a protocol is updated and implemented into the system, I don't have to check my email. It's right there on my phone. There's probably a better chance of me checking my phone than my work email sometimes. So we just talked about the mechanism of the EMS advisory. Tell me why the OCMCA commonly puts out an EMS advisory.
We only put out EMS advisories when it's really important that everybody gets the information in their hands in a timely manner. Just like you said, not everybody looks at emails all the time, but you've got your phone, you got your app, and you've got it right in front of you. So it's very easy to be able to say, oh, look what the OCMCA put out today. This is important. And you get to read it right there in front of you. We share them by email with every EMS coordinator and chief and CEO by email so that they are aware of what's going on.
So the most recent one was EMS Advisory 58, COVID-19 protocols ending effective 9/23/22. Dr. McGraw, give us an overview of what these protocols were and why they're being suspended.
Well, thanks, Geoff. It's actually a good idea, I think, to kind of go back to where we were early spring of 2020. As we all remember, we were confronted with the emergence of a life-threatening pandemic that made not only everyone providing medical care in this country more vulnerable than they had been before, but we were also confronted with something that science had very little understanding of. In order to protect the people, as we had seen in where it had emerged earlier in Asia and specifically in Central and Western Europe, we knew that as this came across the oceans, it was going to impact us. But we didn't want it to have some of the same impacts it had already had, killing doctors, nurses, and EMS providers in Western Europe specifically. Because we had to sort of create policy with limited knowledge, admittedly, we put policies in place that were really designed to protect our providers and the patients that we cared for. These were things like the appropriate use of PPE, that the PPE had to be provided to the providers from the hospitals, just like we, exchange IV kits. We wanted to make certain that we had appropriate ways to decontaminate our vehicles, how to get in and out of the transport vehicle safely, and how to transport patients that seem to be symptomatic with the least amount of risk, although albeit we couldn't eliminate the risk, but try to minimize the risk as much as we could to the providers, especially to that individual provider in the back. That's kind of the total that impacted, I think, our providers the most. There were some other protocols that had to deal with transport or decisions when patients didn't want to be transported, how to affect that. But really, the ones I think the people felt the most anxious to get rid of were, having to wear a mask at all times around other providers or, in the vehicle, even when you didn't have an infectious patient. Fortunately, we've been able to eliminate those, and I think do so safely. But I also want to make certain that people understand when the original intent is to try to provide people for safety, since we still have COVID patients, we're really relying on people to continue to take their own best interest at heart. And we actually have a communicable disease protocol that it remains on the books, is very functional. And whether it's respiratory influenza or your patient looks like they may have severe COVID or tuberculosis, it doesn't matter if it's a communicable disease. We would still insist that you follow that particular protocol to protect yourselves and the people you work with. So this is one of those where I want people to be careful not to think that we're removing the COVID-specific emergency protocols, but that takes away any requirement to do anything for communicable disease. We had a policy and a group of policies and protocols in place before COVID had even emerged on the scene in the end of 2019. And those diseases remain to this day. And I want people to look out for the safety of themselves and their partners at all times.
Thanks, Doc. So, John, protocol guy, bottom line, what does this mean for protocols? Those protocols go away. And as Dr. McGraw said, we're using common sense of when we do utilize our BSI. And obviously, that's probably in a protocol. Which protocol is it in, and what does it mean to me?
What it means to you, Geoff, is this basically. We're going back to where we were before COVID, and there were protocols on the books, as Dr. McGraw said. Protocol 8.7, communicable diseases, talks about when it is appropriate that you should be wearing a mask. And it indicates if a patient has a fever above 100.5 with headache, malaise, myalgia, cough, or shortness of breath, difficulty breathing, or talks about several different types of rashes distributed over the body, trunks, legs, preceded by a fever, you should consider the patient to be airborne and contact contagion, and the crew should don N95 or higher gloves, goggles, and face shields. And it should also be noted, whenever you're doing an aerosol generating technique in protocol 818 infection control, it indicates there that you should be wearing goggles. So we're only taking away a couple different things and a couple different situations, and we only added a few things that we should have been doing before.
So it seems like the COVID-19 situation and all the protocols that we had and everything we learned during that time helped to identify other routes of transmission that maybe we needed to shore up when indicated. So if there's a potential for particulate in the air, we have respiratory and eye protection because we don't want to give it a route of transmission. If something's gooey and wet and not mine, I'm going to put gloves on before I touch it. It's pretty much common sense, and these protocols have been updated and clarified, I think, to a more common sense and safer approach. And again, that's protocol 8-7 communicable disease for those of you who want to look a little bit further. Bonnie, does that clarify it for us?
Yes, I think that's very clear. Also, any agency can develop their own internal protocol or policy that says what they want their providers to do. And I have been taking a lot of phone calls over the last week from those people to say, what should we do? And I'm like, if you feel it's relevant, develop a policy internally of what you expect from your personnel.
Just should be noted that this is the minimum. They can increase their level of coverage, they increase their amount of PPE that they're wearing. They can't do less.
So one of the things that's always good to note is that a protocol is law, it is rule, and it does provide the minimum expectations of care on scene for an EMS patient. But any EMS agency or titled at the state as a life support agency certainly has the right to increase the expectations beyond what is in those protocols. So as long as you're not breaking those protocols and those expectations are increased, that agency fully has the right to write policies, SOGs, or SOPs that would empower that. So if there's an agency out there that fully believes that their personnel needs to continue to wear masks on every call, that is up to that agency. But that agency can't tell them to not wear it when it's indicated by protocol. So it provides a level of safety that is a minimum that the agency can then identify and then go higher as needed based on the conditions of their patients. So speaking of common sense and policies, hospitals are still going to require you to put on a mask and put a mask on the patient every time you come into their hospital. Dr. McGraw, why is it different at the hospital?
You know, we, unlike the Medical Control Authority, have to operate in compliance with the state public health code. And until such time as it is changed, our hospital health systems are going to require this. I will admit, I think for some folks, it can be kind of frustrating because they say, look, I'm not here because I have any respiratory symptoms at all. I unfortunately have injury to my ankle, or I fell and dislocated my shoulder. The pushback on that is there are many people in our hospitals to this day that still have COVID-19. Now, they may be admitted for something else and then they test positive. That has not been uncommon, but some are genuinely ill with COVID-19. Not everybody benefited from the vaccines because their immune system doesn't make antibodies even when they're vaccinated. Not everyone was willing to be vaccinated. And we don't exclude people from our buildings based on whether they have or have not had a vaccine. We do, however, protect everyone we possibly can, because remember, in a hospital, you've got two cohorts of people that I think are most worthy of protection. Those for whom their immune system doesn't protect them like it does you and I, as well as other people who probably are benefiting from an immune system. They don't have any symptoms, but may be indeed positive for COVID-19 unwittingly and give it to the group that I mentioned first. Because of that, every hospital associate, every visitor, every patient, every EMS provider that comes on our campus has to put on and wear a mask. If you don't have one, we'll obviously give you one as you arrive and make certain one is on the patient. But I understand the dissatisfaction people have felt. And believe me, I have people say, well, I'm just here to use the pharmacy. Why do I have to wear a mask? Well, it's on our campus. Our campus is up to the public health code. We and you are going to be compliant. Remember, however, nurses and physicians and people that work here for 10, 12, 14 hours at a time, we're wearing our masks the entirety of that time. So while you may not be happy to wear it for the short time you're on our campus, just remember, we have to endure it a lot more than others. And we do so because we're looking out for the safety of everybody.
Absolutely. Big box full of sick people. Makes sense just to put on a mask while I'm in there. You're not in there very long as the EMS provider. I get it. All right, let's move on to the next thing. Let's compare and contrast state protocols and updates to OCMCA protocols and updates. There's this problem recently that's been identified that EMS providers receive emails and the Wednesday update from the state of Michigan, and this may create confusion regarding what is a state protocol or rule versus what is practice in Oakland County. And it can be confusing if the state sends you an email and say, here's the new protocol and we're the state. Well, an EMS provider might say, okay, but there's a conflicting protocol in Oakland County. Which one do I follow? Bonnie, state protocols versus OCMCA protocols, which do I follow?
You follow the OCMCA protocols 24/7, 365. That's the bottom line. The state comes out with protocols on their own. MCAs have the right to accept or deny. They may change it up a bit, but it's always approved by the state before it's implemented in any MCA. Bottom line, you follow the OCMCA protocols at all times.
Dr. McGraw, anything to add to that?
She said it exactly right. Where I think is we ought to really tip our hat to our colleagues at the state. They are trying to write protocols statewide that have a greater capacity to be applied more uniformly throughout the state. What a great and effective down the road benefit that's going to be. But you can just imagine how hard that is in such disparate communities like, say, Ironwood, Michigan, or Traverse City, or Detroit, Michigan, Flint, Kalamazoo, or places like Farwell. These are communities that have different capacity, different needs, different populations, different transportation guidelines, and different densities of facilities to whom they can take patients to. Because it's hard to write on the state, and I do understand the challenge they face, protocols that'll cover all those different and disparate communities, the EMS Act very wisely gave medical direction to the local MCA at their discretion. As Bonnie correctly pointed out, protocols that are adopted or recommended by the state can be adopted by a local MCA, but they aren't required. Just the opposite. We are required to write our own protocols and have them approved at the state through the QA task force, which we continue to do to this day. The simple answer is when in Oakland County, you follow the Oakland County MCA protocols. Hard stop.
Bonnie, I get these Wednesday updates from the state. We talked about OCMCA protocol app notifications and emails from the Med Control about all these protocols. So it sounds like no matter what I get from the state, no matter what I get from Med Control, follow Oakland County protocols first, unless state protocol is the protocol that our Med Control has adopted. So if I was to open up my protocol app and I start going through all the protocols, I might see some that the header says state protocol. That's the one our county adopted. And then there might be some that say Oakland County at the top. That's because we didn't adopt a state protocol. We decided to have a modified version of that. Is that a good summary?
Or a state protocol doesn't even answer the question that we put a protocol in place for, that it was a novel for Oakland County and a condition we encountered, and a protocol written with the participation of our providers in our county, wrote it, provided it to our providers, the state approved it, and it's specific to Oakland County. That does happen too.
Yes, I love that the state is emailing out the Wednesday updates to all of our providers in the state of Michigan. That is relatively new in the last year or so. I applaud them for that. The problem is it can be kind of confusing when you get those and you see protocols in there. The easy answer is go to our protocol app or go to our website, look up the protocol and make sure we are utilizing either the state format or we created our own.
So currently, Bonnie, right now, there's not really a problem, but a potential that there is information put out by the state and information put out by Oakland County Med Control. And one of the things is that every single EMS provider is registered with the state of Michigan, and they have that email address directly with them, and they can have that direct line of communication. Right now, Oakland County Med Control is putting together a system that would essentially do the same thing. What is this system going to look like, and how is it going to address these problems in the future?
So the roadshow that we've been doing, John and I have gone out to almost 20 agencies now to do the roadshow. And one of the things that came up was this specific issue of I receive emails directly from the state, but I don't receive emails directly from the OCMCA. Well, we're going to solve that problem in the next couple of months. So where we can create a system where we can communicate directly by email with every provider in Oakland County. It's not here yet, but it will be within, I would say, 2 months.
John, you and I were talking recently that some providers are now getting some emails that's saying they're now like linked with Oakland County Med Control, and it raised a couple flags like, hey, what's going on? Give our providers that may have received these emails some context so they understand what's going on.
So the state gave us the ability to create Oakland County Medical Control Authority as an agency in the state licensure system. Just like you're affiliated with your agency, whether it's Beverly Hills, you're affiliated with Beverly Hills, or Oxford, you're affiliated with Oxford. It gave us the ability to affiliate your license with Oakland County Medical Control. This was important for a couple of reasons. One, Dr. McGraw, as the medical director, needs to know who he's providing medical direction for per statute. So we're getting him that ability, and it gave us the ability and access to emails provided on your state license so that we have the ability to create an email list to send you updates. So you're going to be getting these emails that say you are affiliated with Oakland County Medical Control Authority. So an email went out to your EMS coordinators to that effect. We apologize to those that got those notifications prior to that email going out.
And if you do get an email like that, you are questioning it, you can forward it to John at qi@ocmca.org. He'll let you know if it's legitimate or not. Okay, so one of the biggest reasons we're getting geared up to talk to every single provider is that there's a lot of protocol changes being made right now. And it's not just random that all of these protocol changes are going on. Every single medical control authority, every 3 years, has to go through a process of reviewing and reapproving every single one of those protocols. Bonnie, what is the 3-year review process and why do we do it?
So as you said, it is required by every MCA in the state of Michigan to review their protocols every 3 years. We do it because we do need to evolve as a system. So there's a really good reason to do it, to make them better every time. But also it's in state statute that we have to do this. And it's upon the Medical Control Authority to do that. So we did it, started last summer and went through to about January and February, creating the protocols with a lot of our providers' input, and we sent them up to the state.
John, you're a protocols guy. Give me the mechanics of this real clearly in just a few sentences. How does the OCMCA facilitate this process and go to the state?
The process was given to the Protocols Committee. Protocols Committee reviewed each and every protocol, cross-referenced any reference to other protocols, and made sure that they were consistent across all protocols using the same language and the same verbiage, because at 3:00 in the morning, we didn't want providers arguing over which protocol should I follow. This one says this, and this one says this, and it's treating the same patient.
So what I'm getting is that over time, science changes and evolves and may need us to change some of our tactics of how we treat our patients or even assess them. And then other things are maybe a list of items that we've identified over the years of, hey, these references to other protocols, how they're numbered, how they're structured, the size of the font, the size of this and that. Cleaning them up is absolutely necessary. And out of a 3-year review process, it gives us a timeline benchmark, put it on the calendar, get it done so that we can, like Bonnie said, evolve in a very objective manner.
Yeah. And so what you have is sometimes you have a protocol that you want to make a change to, and you unwittingly make it not match another protocol that you didn't even know was referenced that protocol that you changed. And that whole process is to clean all of those things up, the things you were indicating and inadvertent errors made during the change process prior to 3 years.
And also, we've been hearing from our providers through our roadshow that some things don't make sense. And sometimes we explain it and go, nope, that doesn't make sense. We're going to make that change. So it is really a system approach. It's not just a protocols committee approach. It is a system approach to creating our protocols.
So it's a mechanism to assure that we keep it moving down the road. And it's a process. So give us an update regarding this process status.
After it goes to protocols, then it goes through the entire system. And the entire system reviews the protocol changes, approves them, and then they go up to the Quality Assurance Task Force.
So when you say our entire system, you mean all of the other various committees in the order all the way through to PSRO, board of directors, basically signifying that these protocols, we all agree as a team, Oakland County Medical Control, its hospitals, EMS agency says this is what we want standard of care. And then we send it to the state, and the group that reviews it is the Quality Assurance Task Force, or the QATF. And then they review it and say yes or no.
And also the state also has the final say. Does this get approved or not?
Dr. McGraw, this process is not excluding our EMS medical director or physicians. This is not more of a mechanics and litigious. This is about patient care. So, Dr. McGraw, can you give us an update on how the process is going at the state level and updating our protocols for patient care?
Yeah, sure, Geoff. This is really, I think, a wonderful way of a system as the science changes to change with it and to make certain we're doing the best we can for the people to whom we provide care. You correctly point out when we say it goes through our process, that includes the physicians committee, the medical control board, our board of directors. And when they actually go to the QA task force, I joined Bonnie and John when we're questioned about the changes that we've been made. Because candidly, sometimes at the state, they will say, we really like this change. We love this change so much, we'll even put it in a state protocol. Or they might say, this change doesn't seem like you need to make it. Tell us more about that. So we're there to sort of provide background. Maybe it's partly due to the geography or the hospital availability in Oakland County, or maybe our appreciation of the new way of doing things is not entirely shared by the QATF or its physicians. That's the thing about medicine. You really have to take the great overlook of the best intended medical minds to provide sort of final analysis of whether or not something should be implemented to a community. It doesn't mean we'll always agree, but I think there's a lot of really great compromise that occurs when we are, as a system, presenting our best ideas to the state, and the state says yes, no, or tell us more about that. I think that's a really good check and balance to make certain that there isn't some harebrained medical director somewhere, hopefully not me, putting things into the protocols that makes no medical sense or isn't consistent with current medical practice. That's the kind of check and balance which protects ultimately our public. And we should be grateful that even though it's a little bit like watching sausage get made and it's a little cumbersome, along the way, you hope that that group of good, well-intended minds is coming out the other end with the best indicated protocols for our communities.
Absolutely. As all these protocols are being approved, eventually they're going to have to be implemented. I'm guessing they're not just going to be dropped on all 3,000 providers at once. What can EMS providers expect as these new protocols are implemented over the next year?
We will be creating education for each protocol if necessary. Some protocols didn't get changed very much, so it might just be a crosswalk that you'll see. Others will have more education to go with them so that every provider in Oakland County understands what the expectation is in the protocol for our providers.
I know John and I have had a lot of discussions on how we're going to make it as simple as possible for every single EMS agency coordinator or provider to understand what changes were made and then access information on how to learn about that protocol. So we're doing everything we can to make it clear and efficient. Thank you guys for joining me today. I think this was a great use of our time today, and we'll get this out as soon as possible to the people. Have a great day. That is all for the show today, everyone. Thank you to Dr. McGraw, Bonnie, and John for joining me. Please email us your feedback and tell us what you think about the show, or send us ideas for future episodes to Geoff, that's Geoff, at OCMCA.org. Thank you for listening to the Med Control Monthly Podcast, providing the latest updates, information, and trends to and on behalf of the EMS agencies and hospitals of Oakland County, Michigan. Have a great day.